All right, we're going to get started. I hope everyone enjoyed lunch. So our first speaker for the afternoon session is Marc Carmichael. He's currently a medical student here at Stanford. He earned his PhD in biomedical engineering and has an interest in the utilization of big data with the goal of reducing the global burden of disease. Today, he's going to speak to us on climate change and pediatric asthma.
Thank you. I'm pleased to be here. Like Lori said, so I spent a lot of time the past couple of years working at a health tech company called Komodo Health. And after coming back to med school, we learned a lot of great things you can do with big data. So a lot of what I'm going to talk about is using that data to try to understand, pretty much do health surveillance and try to understand how different outcomes are affected by different variables. So one of the things you've heard about today, talk about is climate change. So climate change, as you know, there's been an increase of heat, increase of wildfires in California. You see what's going on in the East Coast. And I know early on the focus was, biologically. So what populations are most affected by this? And there's different ways you can think about it. So, you have different factors at the individual level. You have genetics, things like that, genetic predisposition. You have other factors, social determinants of health, and environmental factors that can affect someone and make them more predisposed to have for health risks. So what we wanted to do is take a look at locally. So locally, around a wildfire smoke event, get a sense on how the smoke wave affects health risk in children and what populations are most vulnerable, looking at different variables, looking at social determinants of health and looking at health outcomes. So what we did is, looked at a local wildfire event in California, Northern California in 2018. We also looked at some data in 2020, but this is 2018. And just to answer this study, let's just see if we can get a sense of what were the adverse health outcomes for children around a wildfire smoke event in Northern California. And we also wanted to examine different factors. So, health outcomes are, first we looked at was asthma exacerbations. So exacerbations are defined by whether a patient had a systemic steroid administered and there was an asthma diagnosis within a day or two of that. Same for emergency department visits, whether they were associated with asthma. So there was an asthma diagnosis on a claim or any ED visits. And we looked at rates per 100,000 child per day. The data sources were, one was the Komodo Health Healthcare Map. And a Komodo Health Healthcare Map is a large administrative claims data set that has lab data, diagnoses, procedures, but it's updated near real time. So, we have data like with a lag of up to a week or two. So, we were taking a look at what's been happening on the East Coast. So we use that. You can take that data and you can link that by location to, census tract data or the ACS data, wildfire smoke data to get a sense of how, some of these factors in where someone lives, how does that modify the effect of wildfire smoke for a given population. So some of the factors we looked at, so with this data, we have a patient-reported race. So we looked at race data, and you see 4 of the social determinants of health that we looked at. Just one was poverty. We looked at home ownership. This is all from the ACS. Education, the fraction of the population that had less than a high school diploma. And another thing we looked at is we looked at the zip level, chronic particulate matter exposure. You've heard a lot about PM 2.5 and triggering and sensitizing airways and leading to worse outcomes for asthma. So we looked at the annual average daily PM 2.5 exposure, the particulate matter 2.5 exposure in a given zip 5. So just to the bottom left, so in the data set, the Komodo healthcare map in 2018, we looked at children under 18. It's about 1.6 million kids, 10 counties during the smoke wave period, which is about 2 weeks, and used a non-smoke wave period for comparison, which was a month before. So I'm just going to go a little bit about the data. So what we found is that, I'll go over the definitions again. Asthma exacerbation was a use of systemic steroids with asthma diagnosis on the claim. Asthma ED visit was the same for ED visit, and any ED visit was for any diagnosis. And we looked at rates of these health outcomes. And we saw that there was increased relative risk of having just any ED visit, 8% during a smoke wave compared to non-smoke wave period. The relative risk of having an asthma ED visit was 27% increase, and then for exacerbations was 76% increase. And this was for all the kids. And then we said, let's go a little bit further and let's break this down by race. For patient-reported race. So patient-reported race, so these groupings are, it's not all of the patient-reported race, but these were the groupings that didn't have any other race that was also reported. Those were excluded. So this is for Black African-American, it's Black African-American only, and for white, it's non-Hispanic, non-Black white. So this is even a smaller subset of the population, but what we saw that there's a differential effect of smoke wave on rates of asthma exacerbations in children. So you see and it's worse for Hispanic Latino population, second most for the AAPI population, and Black and African American, and the white population was the last. This is stuff that we've seen in a lot of other studies. Social determinants of health, something that we know. You also can see that, and it's quite small here, but the utilization of just ED visits at baseline and during non-smoke wave period is different across races, and a lot of it are the results that you would expect to see that you've seen in other studies. So, the highest utilizers were, Black and African American, followed by Latino. But the question is, we see a lot of these studies look at racial disparities in health outcomes. And we know there's social determinants of health, and it might look like there's a racial disparity, maybe, but are there other factors that are contributing? And we know that there are other factors that contribute. And we wanted to take a look at that, see if we could explain some of what we see that maybe appears to be a racial difference by some of the factors that these patients are exposed to. So we looked at a few, not all, just 4, and this is preliminary data, just to see if we could do this. So we looked at some socioeconomic variables. We looked at median household income. It's a lot higher in the Bay Area, so that doesn't stratify as well. But we also looked at poverty. So those are the 2 measures we looked at. For environment, we talked about annual average particulate matter exposure during non-smoke wave periods throughout a year. So this would give a sense of just what levels of particulate matter a person is being exposed to outside of a smoke wave in their zip. Education, we looked at, bachelor's degrees, and we looked at, the proportion of the population that doesn't have a high school diploma. And housing stability, we looked at home ownership. And so I'll start with poverty. Oh, you can see my pointer gray. So in poverty, so what is this here? So for poverty, we split the population up by zip. intertertiles of the lowest and middle and highest poverty. And this ranges from like 10% to all the way up to like 25% for the, the boundary of the highest. But what we found is that, during non-smoke wave period, you still see a relationship between asthma ED visits and the higher poverty. But for a smoke wave, we actually saw the effect is actually highest for folks with the living in the highest poverty. This is something that we've seen we've seen in other studies, but if we go to the next variable we looked at regions with the highest proportion of people without a high school diploma. There was a 45% increase in the risk of asthma ED visits. And go a little bit further, looked at home ownership, less home ownership. There was an increased risk of asthma ED visits. And for this average daily particulate matter exposure, there was increased risk of asthma ED visits. What was interesting about this, and I'll go into it with the conclusions, is that the relative risk and the relative rate difference in the middle and the highest tertiles was roughly the same. It's around 30%. And if we look at, so I didn't put the ranges of the PM 2.5 here, but for the lowest in the middle tertiles of chronic PM 2.5 exposure, it's within the good air quality range. So up to like 10 PM 2.5. And only in the highest, you get slightly into the moderate range. This is so this suggests that even small amounts of PM 2.5 exposure cumulatively could actually predispose a child to worse outcomes with an acute smoke wave event. So what's the relationship between these regional factors and the racial makeup of the region? I showed you these racial differences in outcomes. I showed you differences in asthma outcomes by just aspects of a person's environment. But what are the relationships between the two? This is what I showed you. So we looked at that. So we looked at, within these tertiles, what are the racial makeup of those groups, and is that consistent with what we've seen in the racial differences in asthma outcomes? And what we do is we do see a relationship. So for poverty, we see a similar distribution where Black and Hispanic children more likely to live in areas with the higher poverty. Black children really had a significantly higher likelihood of living in an area with higher average particulate matter exposure, and then it goes down. But take-home message is that the relationship between race and these other factors that are in one's environment is consistent with what we see in the racial disparities, which suggests that a lot of these other factors are contributing, and these are factors that we can that are addressable. So just to conclude, we show that there are racial disparities in the risk of asthma exacerbation and ED visits for children during a wildfire smoke wave, and this is locally. And we saw that the racial distribution, there was an unequal distribution of the races with other variables that we think are associated with poor outcomes as well. So what do we conclude from this? The most vulnerable patients are patients lower economic security, more poverty, least housing stability, less home ownership, lower education, and chronic particulate matter exposure. And so what does that mean about action that we can do? Well, first, just being able to link this type of data, 2018, like I said, we've been able to look at 2020, and we're going to repeat this work for the East Coast. Just collecting this data and the power of linking it to other types of data and to answer these types of questions, to identify these factors in the regions of most at risk is a very powerful tool that we can use to identify ways or areas where we can address. So for housing stability, you know, what do we think? More home, you know, if you own your home, maybe you have a higher likelihood that you can, you know, have a clean air sanctuary. You can control the air quality in your home. Where if you don't, maybe it's less possible. So the things we can do are, you know, perhaps setting up clean air sanctuaries in areas that we know are less vulnerable, more vulnerable, areas that there's less home ownership, or we can provide portable air filters for folks. You know, education equity, you know, a lot of what we saw about folks having the lower high school education could be related to healthcare literacy, maybe language barriers, things like that. So I think, you know, increased community-based education could help address that gap to help patients have more informed decision making. And just air quality in general, I talked about that when I showed the data, that what we see is it suggests that even lower levels that are not in the range of unhealthy air quality cumulatively could have effect of predisposing kids to poor outcomes when an acute event happens or acute wildfire smoke exposure happens. So perhaps re-examining air quality standards to take into account, or just looking deeper into that study of cumulative low-level PM 2.5 exposure is something that we can look further into. So again, I wanted to thank the organizers, Dr. Cornfield, Lisa, and I also wanted to thank a lot of this work was done by the data scientist I work with. His name is Ben Sirio. I just wanted to thank him and Komodo Health allowing me to use their data for good and to present this work.